Good morning, everybody, and welcome to the E-QIP webinar on client and family engagement and quality improvement experiences from the community mental health and addiction sector. We're very happy to be with you today, and we hope that this topic will be of use to you and of interest. We've had lots of different organizations approach the E-QIP team and ask for more support and resources on client and family member engagement within improvement work. So we're hoping that this is valuable to you. We're very lucky to have some panelists with us today that have worked with the E-QIP team to implement quality improvement methods and tools within their own organizations and initiatives. And they'll describe their experiences in client and family member engagement through this process. The E-QIP team uses a language of client and family member, and Health Quality Ontario, through some of the resources that you'll see through this organization, uses the terms patients and caregivers in their supporting resources that will be presented to you. When we refer to clients, what we mean are individuals that receive a wide range of care and supports from community mental health and addiction agencies. HQO uses the language of patients to describe individuals accessing healthcare services from a broad range of sectors, including mental health and addiction. Family members or caregivers are individuals identified by clients that are part of their recovery journey. Engagement of clients and family members for improvement occurs when clients and family members are part of a quality improvement project aimed at improving client outcomes by addressing a specific problem. So I'm sure there's lots of different ways that you've included client and family members within service or program planning tables and initiatives, but what we are really talking about here are improvement projects, specifically where there is a specific issue that you're working on and coming up with change ideas and measuring to make sure that the efforts that you're putting into these change ideas being implemented are actually working and improving care and outcomes for your clients. The goals for the webinar today are to discover resources available to assist with client and family engagement and quality improvement. We hope you learn about the value of client and family member engagement and improvement work from both the client and the health service provider perspective. We also hope that you come away with understanding some practical steps required to recruit and engage client and family members in quality improvement and in a meaningful way. And at the end, we hope to have some time for some questions. We've also noted some questions and challenges that were noted through our registration process, and we're hoping that this question gets answered for you today. As I mentioned at the outset of the webinar, we are very lucky to have some champions for client engagement and family member engagement through our webinar today. I'm not one of those experts, but I do like working with them. I am Jenna Hitchcox. I'm the program manager for E-QIP, and I'll be helping facilitate the webinar today. We also have Lori Dunn on the phone from Health Quality Ontario. From the CMHA Cochrane-Temiskaming Quality Improvement Project team, we have Kathy King, who co-led this project with her colleague Deb Pultz. We also have Louis Poirier, who is a quality improvement team member from the Kirkland Lake office, and he also identifies as someone, client that has used CMHA services in the past. And Rob Lilly is a volunteer with this organization that has also been a quality improvement team member of the project that they'll be speaking to. And we also have Janice on the line to support this work that this organization completed with the E-QIP team and continues to work on today. From the Center for Innovation and Peer Support, we have Betty Lou Christie, who's the QI project team lead for this work and also director for the Center of Innovation on Peer Support. She works in the Halton region and also identifies as someone who is living with her own experience as well as a family member experience. A little bit about the E-QIP project is that it is a partnership project between Addictions and Mental Health Ontario, Health Quality Ontario, and the Canadian Mental Health Association, Ontario Division. It started in 2016, and the mission and the goals are really to ensure that the community mental health and addiction sector understands and applies quality improvement tools and methods within their work to help achieve better outcomes for clients that access their care and support. We do this in a variety of different ways, including one-on-one coaching support for organizations, training and education opportunities like the webinar that you're participating in today, as well as we have our online community of practice where we host a set of resources as well as can engage in conversation with each other about quality improvement in our sector. So this is a definition of quality improvement in healthcare, and we hope that it helps set the stage for what we'll be talking about throughout the webinar. So quality improvement is a systematic approach to making changes that lead to better client outcomes, stronger system performance, and enhanced professional development. It draws on the combined and continuous efforts of all stakeholders, which include healthcare professionals, clients and their families, researchers, planners, and educators, to make better and sustained improvements. So as part of the E-QIP team, we use different models and principles for guiding our work to help organizations understand and apply quality improvement that will hopefully lead to improved client outcomes. So the first model we use is the model for improvement, and this model really encourages you to think about what is a problem, how do you know it's a problem, what changes can we make that will result in an improvement and hopefully fix or at least improve the problem that we've identified. And with those change ideas, we can do small plan, do, study, act cycles or small implementation tests to see what works and what doesn't before we do full-fledged and full-blown implementation across either a program or an organization. So it really encourages you to start small and grow once you know that an idea works. The domains of quality also guide our work, and that these are the 6 domains of quality that Health Quality Ontario is advocating for across the province for organizations to think about in terms of aspects of care that are important for a high quality healthcare system. And the quadruple aim on the right-hand side of your screen is really all about what the end goals of doing quality improvement are. And it's better health for the population, better care for individuals, lowering the costs for improvement projects, and improved provider satisfaction. So those are really the 4 ultimate goals that we're trying to achieve by implementing the model for improvement, thinking about the domains of quality, and helping organizations implement these tools to drive the changes that you see in the quadruple aim model there. So I'm going to pass things over now to Lori that will talk about some resources from HQO on client and family member engagement to help guide your work and give you a starting place if you're thinking about expanding your client and family member engagement levels or just starting out.
Everyone, for inviting us. We're here to do a very quick little setup about tools and resources and then move on to the important work, which is to hear from your cohorts in the field and the work that they have done. So, although I don't think I have controls, Jenna, so if you don't mind going on to the next slide. I didn't get a presentation. So who is Health Quality Ontario? Formed in 2011, Health Quality Ontario brings 3 arms of quality together: evidence and standards, so what is best practice, public reporting, where are there performance gaps in the system, and quality improvement, which is really the execution arm or the exploration arm. So how are we going to make those improvements that have been identified and that we understand from the evidence? I myself work for the Quality Improvement Plan program at Health Quality Ontario, and that's one of many supporting programs. We find that the program provides a cadence and a structure, and this is currently used by over 1,000 organizations in Ontario who report an annual quality improvement plan. Next slide, please. So we are the provincial advisor on the quality of health care, and the ministry has directed Health Quality Ontario's efforts through the Excellent Care for All Act and Patients First legislation, as well as sector-specific regulations that help direct quality. Some of the levers that come from the legislation and regulations that impact our program include requirements for hospitals to engage patients in developing quality plans. Another example is the requirement for hospitals, long-term care, home care, and some primary care organizations to collect annual surveys from patients or clients to inform improvement efforts. We're going to show a few examples today just to set things up. And lastly, for hospitals and long-term care, an important lever has been the requirement to have patient and resident councils. Next slide, please. So we are driven by a single-minded purpose, as is the whole health system, better health for all through excellent care for all. And I know Jenna has also already mentioned today the quadruple aim, and it's through that quadruple aim, referenced through the Institute for Health Improvement in the States, that patients are positioned as one of 4 key drivers to system quality. Next slide, please. So we have a patient engagement program. We hope you'll go onto our website and find it. It's full of resources, and it's been created with our own patient council that we work on and take a look at things at a system level. So what do organizations throughout the system need? What are they telling us they don't want to recreate the wheel? And this work that's been going on over the last 4 years means to us that patient engagement is patients, families, and health providers actively collaborating to improve Ontario's health system. And we hope to foster an empathetic culture. And so to support organizations in this work, there are tools and resources. They have been co-designed at times by our own patient advisors. We've had a lot of learnings ourselves into how best to support patient advisors in this work. And we hope that those tools will really help you in your work. We have several hyperlinks in this presentation that take you right to the tools. Next slide, please. So this is a picture of the Ontario's Patient Engagement Framework. It's based on existing frameworks that you may already know, like Carmen's framework and the U.S. Public Health Framework. We wanted to give it a little bit more of an Ontario context, and as well it's important to consider the community, primary care, and home care context when we think about this framework. The framework has provided us as an organization a useful structure to reflect on our needs. For instance, in our program, most of the submissions we receive actually concentrate on work at the organizational level. So if you take a look at the framework, you can see across these domains, there's obviously the interface between the provider and the client. There's the interface at the program or the organizational level, and then there's also influence at the policy level. So for our program, the QIP program, most of the organizations give us information that's more at the program level. But the difference is in the community, and I think you may also find that the same for yourself, where what's mostly relevant to staff and clients that are involved in this work is at the interface of the provider and the client. And underneath that, you can see there's a spectrum of engagement approaches. All are good. But what we have learned, and certainly understood through the literature, but have seen ourselves as well, is that more successful organizations choose a variety of approaches. So the approach on the left is share, and then consult, and then deliberate and collaborate. And as they say, it's a spectrum. So it wouldn't be enough if you have a council at your work to know whether your council is consulting or deliberating. Only you can know that. And as you are developing your own patient engagement methods, you may start off with the council consulting, and then as efforts mature, later on you find that they participate more in terms of deliberation, and then finally collaboration. And just like anything else in quality improvement, it is a bit of a journey, and you have to start where you are. So we did find most organizations, when the first few years that we were doing this and having organizations report on it, they were very focused on how to recruit advisors and needing terms of reference for committees. So the setup, which is only natural, but over a few years we can see that they're starting to use more participatory methods. Next slide, please. So we're going to use this framework in a couple of examples before I hand it off. So this is an example of some information that we collect every year, and we simply ask the organizations who submit a QIP to tell us about the kinds of activities they use when engaging patients in quality improvement. So we do use the term patients very generically. It is meant to refer to patients, residents, clients, caregivers, and families. And again, because organizations report at an organizational level, we don't really get enough information to understand sort of beyond what they're reporting. So what you see along the x-axis here is the variety of activities. And on the far left, you have things like critical incidents and complaints. They're quite a good source of data when you're thinking about quality improvement. Surveys, you see that there is a high uptake of using surveys, and some of that, as I said, is driven by legislation because all 4 sectors are required to collect annual client surveys. You'll see focus groups. You're moving more into consultation and deliberation here. And then another quite frequent response is advisory councils. And again, that didn't surprise us because those are required for hospitals and long-term care. Engaging patients in developing the quality improvement plan was a recent regulation, and you can see the purple bar, which is hospitals, has the highest uptake. They also have a regulation requiring them to engage patients. So it's sort of an interesting way to look at things we find every year, because you can see the impact of legislation on the choices that organizations make, and you can also see some differences between sectors. So the blue sector, for instance, is primary care in this example, and primary care certainly uses surveys quite a bit, focus groups, but we know because they give us a lot of qualitative information as well, that they are more prone to believe that focus groups and community engagement are a more effective use for them than councils. And because for primary care, most of their patients are actually healthy, you can understand that the idea of a council may not be as attractive as when people have a cohort of more complex illnesses. So we learn that, and we also learn as we go along the x-axis towards the far right, where there are more participatory methods, such as patients involved in co-design or patients advisors on quality improvement committees, that they're not chosen as often. So our lessons learned as we sort of follow this and try to support organizations is that a variety of activities are important. When you think about complaints and critical incidents, you have examples of where things have not gone well, and that is very helpful, but you may find that you are trying to solve things for a rare circumstance. On the other side, when you look at patients involved in co-design, you may be focusing more on what works well the most often for the most common activities. So it's all good, but it's important to think about the various ways that organizations can look at that. Next slide, please. So the other thing that we want to make quite clear is that from a little snippet that we get, a paragraph, we don't actually know how an advisory council is being used. For instance, they might be consulted once a year about the quality improvement plan, or they might be deliberating throughout the year on the plan and getting quarterly updates. And that's true really for almost any of these things. So really at the end of the day, it's better that the information comes from the organization. So in our own quality improvement journey, next year we plan to give them these options. We needed the first 3 or 4 years to have open text and sort of see what was coming up most often. And now we just feel like it would be better if they told us. One organization might put advisory councils in consulting and another might put it in deliberating. And this is really a conceptual framework if it helps you to sort of think about it. I think the bottom line is you want breadth plus depth. And while a survey will give you a lot of breadth, things like focus groups and co-design are going to give you a lot of depth. And you want both to really get your answers. Okay, we'll go on to the next slide. So we do have these resources, and now that we've sort of shown you, you can see we really, like you, we've spent the last several years really getting started and thinking about foundational resources. So you'll see a lot of those there. We have tried to put them up so that you don't have to recreate the wheel. Things like terms of reference, recruitment, advertising, things like that. Building equity and diversity is a very popular topic. And as you know, sometimes people are just getting started on their engagement journey and they also want to start simultaneously on their equity journey. Both are very important. So we hope those things will be helpful to you. Communicating in plain language, you know, there's just a variety of resources and they grow every year as we figure out together what's needed. Next slide, please. So this is another example. Jenna, if you don't mind, on the bottom left there, engaging with patients and caregivers, this was kind of a fun project we did. I thought I would There's many choices, but I thought I would highlight this one. It's the one with, in the bottom left. Yeah, right there. That should be hyperlinked. If not, we'll live without that. So this project was really fun for us because we actually wrote that manual with 20 of our own patient advisors. That is great. Thank you. And the whole experience was very different. It was certainly in our program the first time we had written a how-to guide, and the guide came out very differently. If you can page down, you're going to come to our bracelet, Janet. If you just page down on this one. Just go quickly past those first tables of contents. And what our patient advisors told us is that they really wanted this to integrate both patient engagement and quality improvement. So that's what we did, because they feel like they could have really used a step-by-step guide through the process of quality improvement. If you just go down one more, we certainly started with our framework. There it is. So we have this on our website, and this is our Getting Started guide for quality improvement. And we just work together to give examples. So when you're at the Getting Started phase of quality improvement and you haven't really settled on your project, what is the role of the advisor at that point? What are the questions the advisor needs to ask? And we took it through each part of the quality improvement process. And frankly, we ended up with a manual that had a lot more quality improvement in it than I thought we were going to have when we started the process. But it was great to have those advisors on board, and that seemed to meet their needs and what they felt other advisors were that were just getting started in the process. We can get out of that now. Thanks, Jenna. We'll go back to the slides. Yeah, and then if you just go to the next slide. So all of those are hyperlinked in the presentation, so you can get to them quickly. And then we talked a little bit about the framework having both program and service design, like the interface between the provider and the client, the personal care and health decisions, and then the policy. And on a Quorum site, which I know many of you are on because you have your own community of practice on Quorum, we have been posting stories. I think I won't go ahead and just show you one because I think we need to make up a little bit of time. But I do encourage you, if you want, they've all been hyperlinked there. And I thought particularly the one on the left with peer support workers. I know one of the things I often hear from lots of organizations, and I think you all do as well, is that you can't, for the clients who are in the mental health and addictions programs, they can't necessarily just fill out a survey or, do some of the routine stuff that people expect. And certainly that is a common thing. People need really innovative ways of reaching out. So with that, Jen, I think I'll pass it back.
Thanks, Lori. So I'm going to do a little bit of an overview of what we learned from a few different outreach sources that we have for engaging with the sector that you're all part of, and that's the community mental health and addictions sector. We're going to just look at some trends that we've seen across the sector. So we have over 300 agencies working within the sector, and we'll just give you some trends that we've been seeing across the organizations within this field of healthcare in Ontario. So we did a survey in the summer of 2017, and the graphs that you see are the results of about 65 respondents. So not all of the sector, but definitely a good portion. And what we asked were different questions on quality improvement capability and capacity, and quality improvement culture. So we wanted to get a good sense of where we were as a sector in terms of implementing and using quality improvement tools. And we asked one questions about the involvement of clients in the planning and delivery of quality improvement projects and initiatives. And this is the results that we got. So we see about 29% said yes, and 29% said no, about 41% said somewhat, and a few folks were unsure. So we raised this slide so that you can think about where you might fall within the answer to this question. And if it's a no, how can you improve? It's a somewhat, why is it that you're not clear, and what can you do to improve that? And if you're working within an organization that is including clients in your quality improvement work, are you doing it well? And are there things that you can do to improve and learn from each other? Are there stories that you can share to help others with their journey on this topic and important aspect of quality improvement that you might want to share? So that is just some food for thought for this slide for you. The next slide comes from the same survey. So again, about 65 respondents answered these questions from across the 300 or so organizations in the sector. And we asked about who are the key stakeholders that receive information about your quality improvement efforts. So if you're doing quality improvement work, who actually knows about it, and how are you communicating the results out? So about half said that the clients of their organization are getting information about their quality improvement work. And again, we just encourage you to think about where would your organization fall on that question, specifically with clients and family members. How are you actually letting them know that you're doing projects and work to improve client outcomes? And how can you let them know, and how can you engage them in this work? And through the registration process for this webinar, we did ask you to think about some ways that you've included clients and families in your improvement work. And they're all listed here. I won't go through them all, but you can see things like focus groups, committees, panels, co-designing, and hosting some quality related events for both clients and family members. So those are just some things that are currently going on by the attendees of today's webinar. So I encourage you to think about if any of those would be useful to you, and if so, what additional resources do you need to help put things into place. And then we also asked about some challenges or questions that you have about client and family member engagement in improvement work. And one strong theme that came out was that we're not too sure about recruiting members or how the best way to do that is. So we'll hear from experiences today about what you can do to help recruit members to help with your improvement work and ensure engagement right from the start of the project. We also heard, how do you know that client and family engagement is actually valuable for the people that you're asking to help guide your work? And what are some methods of client and family engagement beyond survey participation? And what are the ethics of client and family involvement and information sharing within quality improvement work? And our panelists will comment on some of these issues as we work through some key questions for you today. Okay, great. So we're going to move into our background discussion on the projects that we'll be hearing about today. So I'll just get Kathy from the CMHA Cochrane-Temiskaming team to give a brief overview of the project that they worked on.
Hi, everyone. So at CMHA Cochrane-Temiskaming, we developed a documentation process called the Domain-Oriented Recovery Record. We call it DOR, and it's really using the OCAN for assessment, and from there we develop a recovery plan, and then based on the client goals and the OCAN, we chart according to the recovery plan. And what we realized is we really needed to focus on one aspect, so we focused on the recovery plan, which is based on the OCAN and the client's goals. And what we discovered was that 100% of clients agreed that the recovery plan was helping them meet goals. But the difficulty was that only 55% of our clients had a recovery plan. So we had to look at how can we increase the number of staff completing recovery plans. And so we used a variety of UI tools, including the 5 Whys, Fishbone, Pareto, Process Map, and came up with our change ideas. And now 90% of our clients have a recovery plan. And what our next step is to ensure that we're updating our OCANs and recovery plans every 6 months. Right now we're at about 70%, which is wonderful, but we want to bring that up to 90%. And our next QI tool that we're going to be using is the experiential based co-design with clients. So that's it in a nutshell.
Great, thank you. And I'll get Betty Lou to talk about her project.
Okay, I'll go through quickly. So, can you put the slides back up on the screen eventually? So I'm Betty Lou. So we used to be known as the Enhancing and Sustaining Peer Support Initiative of the Mississauga-Halton-Lynn region. We've just recently rebranded to the Center for Innovation and Peer Support. We're embedded in Support and Housing Halton. The scope of our project is huge. We have 40 paid peer support positions embedded into 11 Mississauga-Halton-Lynn community providers and hospitals across 25 different programs, and we have 24 peer support supervisors. And we also have connection to regional, provincial, national, international collaborations. So the gist of that when we came to the QI project was, how do we possibly focus on something small when you have an enormous piece? There's two of us, Christina and myself, that are now the directors for the center. And the biggest thing we kept coming up all the time was role clarity and role definition for paid, intentional peer support workers embedded in different agencies. And going through the QI process with that, we took all the trainings with E-QIP, went through all the processes to find out that we actually don't have any good qualitative baseline data to work with. A lot of it doesn't speak to what peer support is, and because peer support is based on values, and you can't get outcome measurements on values, but if you convert them to actions, behaviors, then you could measure that. So we actually had to go the route of creating a validated tool, which has been like a 2-year off-the-course path for us, just to get baseline data to start in sphere 1 of our 6 spheres of impact that we're going to be evaluating on. So the long and short right now, just because we're running out of time, is that we've gone through the validity testing, we're going through the reliability testing, we had to go through ethics, we've just pulled the survey out of the field, which actually has an experience-based co-design piece to it. It's all been created and built with the engagement of lived experience, families, peers. All of us who work here have that same lived experience, family, peer lens. Every process along the way through this process has been the voice of lived experience and family. And that's where we sit today in the long and short of it.
Great, thanks so much. So our first question for all of our panelists is about recruitment. As I mentioned before, this is one of the challenges that strongly came out of the registration process. So we're hoping you learned something from this part. So maybe we'll start with Louis, and I'll ask, how were you asked to participate in the Quality Improvement Project or Initiative, and why did you say yes?
Well, thank you. I was asked by a CMHA staff member, and I was also a member.
Sorry, Louis, we lost you for a minute.
Oh,
there we go, you're back.
Sorry about that.
That's okay, I'll get you to start again.
Okay. Just hearing the echo.
Yeah.
CMHA, I was a CMHA staff member that approached me, and I also a member of the Recovery Ambassador Committee. We formed in 2016, and also a member of the Documentation Committee. They wanted to recruit clients with lived experience dealing with the mental health system. And I said yes, because I wanted to provide my input and help others dealing with mental health services.
Great. And I'll ask the same question to Rob.
I was invited by Deb Peltz, who I was on the CMHA Timmins Ambassador Program, and I was familiar with it from there. So she asked me if I'd like to participate in that, and I said yes.
Mm-hmm. Great. And did you have a reason why you said yes?
Well, Well, I hope my experience would be valuable. It's good to feel useful.
Yeah. Good. Okay, and maybe I'll turn it to Kathy to talk about some successful strategies that the CMHA Cochrane-Temiskaming team has used to engage clients and families in your QI work.
Well, I think what was helpful for our client involvement in our QI work, and both Rob and Louis have spoken to this, is that Cochrane-Temiskaming already had strong client involvement through their Recovery Ambassadors Committee, and so they had a strong base participants. And so what we did is pulled from that pool. So either staff or, for example, Deb might have contacted them. And that was for our documentation committee. And then because we were already having clients actively involved, once we had an E-QIP project, it really was based on what we were already doing. So we asked, would you like to carry on a more intensive, because we were just meeting about once a month, and now would you like to meet every 2 weeks through So I would say developing a strong base of client volunteers, and then you can draw from them as required, and also counting on staff to inform clients that there's an opportunity if they'd like to participate.
Great. And I'll pass things over to Betty Lou, and if you can discuss how you've recruited peers and clients to be involved in the work that you're doing.
I think one of the biggest things that we found is, I mean, of course, because we're a peer initiative, and we also already had the base. And our Mississauga Halton Lynn has been so brilliant at having people at their systems table for about a decade now. So that helped to really put some parameters around it. But basically, it was actually making sure that the people that were engaging had the context as to, this is the reason why we're doing this, because sometimes quality improvement is not a tough sell. Sometimes policy governance is a tough sell. So it's trying to make it relatable as to, I know this may not directly help your experience per se today, but this could very much help others who are going to struggle with mental health, substance use, addiction, trauma, bereavement, or any other issues that are out there right now. And that was one of the biggest things that latched people on, was the fact that we gave it to context as to, here's what it's going to be, and also the onboarding to actually give them enough education and background so they had the actual context of the system level piece, and being able to negotiate it's not about I, it's we. So those were some of the things that we negotiated ahead of time. And then, of course, managing triggers. That was really important because we want to make sure that we create safe space and that everybody felt safe and valued.
Great. Thank you very much. So the next question, we'll talk about ways to engage, and Lori has touched on this in the resources with different options of you know, how to ask clients and family members to become involved with your quality improvement work. Maybe we'll start with Rob, and just I'll ask you, what was your role in the E-QIP work, and what made it easy for you to participate?
Yeah, as a member of the committee, and what made it easy was Kathy was always very inclusive. If Louie or I hadn't said anything for a while, she would always ask for our opinions. So we felt very welcome and you know, free to express ourselves.
Great. And Louie, anything to add to that?
No, basically that's what Rob said, that we felt that we were valuable members of the committee. And she was always asking us for input and for agenda items during our meetings.
Great. And I'll flip it back to Kathy about how did you decide on the ways to include clients and families in this project in particular?
Well, for this particular project, we made a commitment from the beginning. If We're going to involve clients. We're involving them 100%, so there's no in-camera. We've all, whether we're staff, managers, or clients, we're all part of the team. We've all committed to confidentiality, because you can imagine when we're talking about completion of OCANs and all sorts of things, there's some pretty confidential stuff that's discussed, but there's nothing in camera. Everybody participates 100%. If we have a documentation orientation workshop, a full day for staff to attend, our clients that sit on our committee, documentation committee or E-QIP committee, they're welcome to attend. When there was the ideas and the diagnostic, all the trainings that were offered by E-QIP, our clients attended, and if it meant that staff were able to travel, then we invited our clients to travel. If someone doesn't have internet access, then I think, you know what, we all communicate by internet these days, but guess what? If you don't have access, then we're going to have a process of printing stuff out and phoning you and making sure you feel involved. Part of the decision-making 100% of the time, not just for some items. And I don't know if you want me to touch on evaluating or leave that till later, but I think the key is involve 100%. So we really don't differentiate between staff, managers, and clients. We're all part of the committee.
Great. And Betty Lou, any thoughts on that question?
Yeah, I agree. We did agree with everything that Kath just mentioned there. We had some stricter protocols at certain points when we were going through the actual ethics process, because we actually have a really strict criteria to follow as far as going through the test, retest, and that involved patients, clients at St. Joe's. So there was a process there that had to be followed. But we provided gift cards and the ability for travel. If people didn't like tablets, then we'd have other ways of doing it on a paper form. Creating that safe space was really imperative. Where we had group dynamics, because there was a lot of time that there was groups through the whole process. So just having really good facilitators there that could negotiate the group dynamics and the choice and control, and recognizing contributing factors, making sure once again that it was all about empowerment and inspiration, speaking in plain language, and very much the fact that we didn't, it wasn't an advisory on the side. We were at all processes with all groups and teams. We were all co-creating together, and we were all working together as one, not as two separate entities.
Perfect. Thank you. And the last question there is about giving feedback on your experience as a client on the team. Maybe I'll let Kathy start, and then Rob and Louis, if you have any additional comments, you can add them afterwards.
Well, I'm not going to put Louis and Rob on the spot, but I have asked them how is it going, etc. But it has been informal, and we actually mainly do it as a team. Though I've done it informally, as we have looked at how are the meetings going for the E-QIP meetings, etc. But we haven't specifically done a formal client experience, so I would just say duly noted. But I think informally, I do get feedback, and if I need to have the odd phone call either to Rob or Louis to just double check on things, etc. Thanks.
And Betty Lou, any comments on that part, the evaluating?
Yeah, we haven't formally evaluated, only because of the fact that because we found out in our journey that there's no good baseline data for us, is that to actually speaks to the value of not just peer support, but meaningful engagement of lived experience, family, patient, caregiver, citizen, resident, community member, however anybody identifies. And I think that this tool, although it will be specific to peer support values and in action as perceived by people receiving services, it will also be adaptable along the way to actually be able to meaningfully evaluate the true innate value that the voice of lived experience and family has brought to all of these pieces of our process. So we've been very much keeping track of all the methodology and the rigor, but particularly so we can go back, and we have anecdotal stuff, of course. So we have, you know, people that are telling us that it was a great experience, or if there was any problems or barriers. But we want to actually formalize that when we actually have a tool that can actually create, take that expertise we've been given by people with lived experience, family members, and actually create it into something that can speak to evidence.
Great. Thank you all. And we'll move on to the next set of questions. For Rob and Louis, when did you feel that your contributions were valuable to the process, and what made your involvement worthwhile? Maybe we'll start with Louis this time.
Can you hear me?
Yep, we can hear you.
Okay, I'm on the computer microphone now, so there'll be less echoing. I felt my contributions were valuable when at the end of the Christmas season, I received a thank you card from the E-QIP committee, and the note I was actually acknowledging how valuable my input and work with the committee was. And also during the committee meetings, seeing the changes on the items, that you can see that there is a change in the way of thinking to change it to more recovery-based initiatives to hear our voices.
Great. And Rob?
Yeah, like Louis, I also got the gift certificate, which is really nice. Great sign of appreciation, and the note went with it. I feel that I do best when it comes to modifying the phrasing on things. I used to be a press reporter, and that's my area of expertise is working with words and shortening them down. So I was always felt that my ideas were received well. So that was encouraging.
Great. And next question I'll ask to Kathy is, what was the value of having a client or family member involved in the quality improvement process and part of the QI team?
Well, I think we have a great team, and I think what our clients have brought to the table is objectivity, especially sometimes when we're trying to make decisions about which direction to go. Objectivity, okay. Wordsmithing and grammar, I gotta give a shout out for that. The use of technologies, you know, what might be the best term to use, technical expertise, and just, I just have to give one example. We were at the ideas workshop. We had an exercise with this paper airplane, and one of our clients was with actually our CEO, director, manager, and like just blew everybody away because his interpretation of the exercise as it related to PDSAs was like fantastic. And so we're, you know, we're all learning at the same time from our clients. So there's just so much value. I think it's critical.
Great. And did you have any assumptions that might have been challenged as you worked through your project?
Who did you ask that question of, Jenna?
To you, Kathy.
Oh, okay. I think, you know, the one thing was, you know, I was thinking, I guess it would be an assumption challenged, is just the strength and tenacity of our clients, and, you know, thinking that we might be providing support to them, and really how they actually are providing support to us in our work as we go forward. And I would just say an example is when we work distance, so we've got 3 different sites, and when I do a shout out, who's in KL, and the response is the 3 L's, Leslie, Lori, Laura Lee, and Louie, like our clients are just embedded as part of our team. They come to all of our meetings, and so that's, you know, I guess that the assumption that was challenged was just how much of a positive impact they would have on our work. Thanks.
Great. And Betty Lou?
Yeah, I would say for us, as far as what was the value of it, I mean, for us, we're on both sides because all of us on the team have lived in family experience, and then we're engaging with people who have lived in family experience. So I think I guess our biggest thing was pushing back against the system barriers, you know, recognizing fully in our roles that there's certain beans and widgets that have to be counted, but to truly get down to the value. So it was kind of like role clarity, role definition. The system per se, and all the 11 agencies wanted an elevator speech of what peer support is, and an elevator speech, and they wanted us to create the role. Whereas actually, you know, the innate value of engaging people with lived experience in family can look different depending on what the environment or setting is. And that's okay as long as they're working from the values of peer support and they're not turning towards, you know, clinical or what the agencies want. So that was one of the biggest things, is that having that big of a team of peers where they meet once a month, the 40 peer support workers and the 24 peer support supervisors. So we always have a way to flush through. So that was something where that kind of gave both Christine and I the courage to stand up and go, no, you know what, we need to do this properly. So I think the biggest assumption was basically the fact that it validated for us that at some point somebody has to go, yeah, but doesn't matter anymore. Like we can't work against the limitations all the time. Like it's kind of like, I know the limitations are there. We really respect system limitations. I understand why we need to have a good evidence path, like all of those things. But at some point we have to kind of go, yeah, but we can't just follow those rules. We have to actually stop and maybe try to create something that's actually going to change the trajectory of a really, what does a quality and a life worth living look like? And that innately speaks to the value of recovery and what the peer support role can bring to the table.
Mm-hmm. Great. Thank you all for those really thoughtful answers. So the next questions are around challenges with engagement and working together. So the first one is for Rob and Louis. What were your challenges that you experienced in the E-QIP work? And we'll start with Rob.
Both Louis and I thought it'd be a good idea to have a glossary of acronyms to help us keep track. But that was the main challenge, was to keep up with that.
And Louis?
Yeah, I agree with Rob. The acronyms with the documentation that CMHA uses, and sometimes how complex the backlog of clients have to wait for the services, and this may in the committee just maybe trying to find a way to improve the wait times. We can see an improvement. And also another challenge was the technology constraints that Kathy was mentioning a while ago. Some of the staff don't have the adequate computers or laptops used to complete the OCAN, self, and their staff reports. And that's because in other agencies they probably do use some more of the computer technology, and I think that would facilitate to lessen the wait times. Everything would go a little bit smoother.
Mm-hmm. Great. And I'll ask Betty Lou this question first. So what were some challenges you experienced in engaging clients and families from recruitment to the end? You're not at the end of your project yet, but to the present kind of state of your project.
I think because a lot of it is, because it is such long-term, that it's really difficult. I think it's helped us that we've had to do it in processes and pieces where we've actually had to engage different groups of lived experience and family, but we've had some core members on from the very beginning. But just the fact that to adhere to proper process so we actually have something we can use in the end, it's a really long process, and that can become very weighted and somewhat boring at times for people, because it would be nice to be able to show some results quicker for people. So that is definitely a challenge.
Right. And Kathy?
Well, I think for us, one is just the distance. So we have 3 sites, and we communicate over the technology. And I think one of the challenges is to keep connected. And I just think that if we didn't have great staff like Janice, the rest of the staff at Janice, like just, ensuring that our clients are able to participate and are kept connected. I think the IT, I think it's for the organization to really value everyone to recognize how important client input is. And, for example, we're wanting to use business Skype, but there's a cost for the client. So, if you get a response, well, this is for the staff, not the clients, then we have to say, well, let's go back to the organization and look at, how, the valuing of clients. And I think the last one is, if clients need to take a hiatus or a break, they can't make meetings, maybe for whatever reason, symptomology or whatever, you're not comfortable, maybe traveling away to attend a workshop, that we really have check-ins and ensure that we're bringing them up to date. So just because you might not feel comfortable traveling a distance to go to a workshop, like what are the highlights, so that we can keep everybody moving forward together. Thanks.
Thank you. Okay, and the last question that we have is advice for others. So to Rob and Louie, what is one piece of advice you would give clients and family members that are interested in participating in quality improvement work? And maybe we'll start with Rob.
I'd say don't be afraid to speak up. Your opinions are valued, so don't feel any shyness on that account.
And Louie?
Yes, I would tell them to do it because it greatly helps the future decisions to improve the quality of mental health services with CMHA to their clients. And we can actually, Rob and I actually were witnessing that during our E-QIP meetings, that we are being heard, and that's the main goal, as to provide quality service to the current and any future clients using the services.
Mm-hmm. Thank you. And from a provider perspective, what would you want to have known when you first started to engage with clients and families and improvement projects? And I'll ask that to Kathy first.
What would you have wanted to know when you first started? I guess this is critical. Do you have administrative support? Because it really starts at the top, and whatever your little motto is, for example, at CMHA, Cochrane-Temiskaming, they talk a lot about nothing about us without us. And so we really need to walk the talk, but it really starts at the top with administrative support, because not only is it involving clients, but sometimes there can be some side to that. So, and actually, I think that's what I'm most proud of Cochrane-Temiskaming is for actually, walking the talk. And so, I think that clients, it's helpful for them to know that there's 100% support for having their involvement, versus maybe somebody at a meeting thinking, oh, we should invite clients. Like, it has to be an organizational support. And I think clients need to be able to feel that.
Mm-hmm.
I just want to say, just like Nike says, just do it. You know, I mean, just make sure that you start involved wherever you start someplace, because the organization is going to benefit.
And Betty Lou, I'll get your thoughts on that question.
Yeah, I'm going to use it from my perspective as being a lived experience and family advisor myself, because I think this is happening a lot still out there. The fact that a lot of times a lot of attention is put on the needs or skill sets of the lived experience and or family member that they're engaging. And not enough emphasis is actually put on the socializing the rest of the team as to the value and the expertise that is being brought in by lived experience and family. So a lot of times it's kind of like you're not actually looking at the whole team and actually making sure that all of the team actually have been onboarded properly. So, and there's a little hierarchy and there can be some issues around that. And I guess because we've lived it ourselves, we made sure that was taken care of. But I think that's a piece that's really, really important.
Great. Okay, well, that concludes our panelist discussion for the webinar. And I just wanted to give a big thank you to all of the panelists that volunteered their time today and did a lot of preparation to give some really thoughtful advice to all the attendees on the webinar today. So just wanted to send out a big thank you to each and every one of you for giving us some really great answers to the questions today. Now, because we had a bit of a time crunch because of the technical difficulties, I'm not going to go through a question time today. However, I will encourage you to ask any questions that you have for the panelists on our community of practice, and I'll go over how to join that and ask your questions on that platform, and I'll do my best to ensure that you get your questions answered through our community of practice. So after today, again, I encourage you to log on to our community of practice that is on Quorum and ask your questions that you might have for the panelists that are incredible champions and very knowledgeable on client and family engagement and improvement work. You can also share one key learning that you took away from today and maybe something that you want to work on with your teams and your quality improvement projects within your own agencies. We'd love to hear about something practical that you can take away and are looking forward to including in your practice. This is all the ways that you can stay connected to Health Quality Ontario and Lori's organization. If you have any questions for Lori, she is on our community of practice as well and would be happy to answer your questions on the resources that she presented and support from Health Quality Ontario through that platform as well. So after today, if you want to become a member of our online community, these are the instructions of how to do so. Essentially, you become a member of Quorum. The website is linked there. And then once you're a member of Quorum, you can click on Join Group when you find the E-QIP Community of Practice under the Groups page. And if you have any questions about how to do that, please feel free to email myself or the general E-QIP emailing address, which should have been connected to your registration process for this webinar. And these are some additional training events that might be of interest to you. Tomorrow we have another webinar on experience-based co-design. And we encourage you, if you're interested in getting even more practical tips and tools to learn about the co-design process tomorrow with us at lunchtime. We will have that recorded and posted on our community of practice for those that have to view it at another point in time. We have a governance and leadership for quality improvement training session coming up at the end of the month on April 26th. It's a full day event and it's for board members and senior leaders of healthcare organizations. So we encourage you to sign up for that if you're interested. It is in Toronto and it's free of charge. And then you can see some Health Quality Ontario webinars coming up tomorrow and in May as well on measures. And this is just a reminder for you that the IDEA's Advanced Learning Program applications for their next round of projects that they coach through a quality improvement project are coming up, and the E-QIP team is here to support community mental health and addictions agencies looking to get involved with that program. They are earmarking 5 spots for the community mental health and addiction sector, and we would be happy to assist you in your application for that type of support if you're interested in doing that. And these are a list of all the webinars that we've done in the past, and you can click on those if you're interested in learning about those topics, as well as all of our webinars and upcoming events are part of our mailing. Our newsletter, they're all included in our newsletter that happens about once every 2 months. And if we have pressing training coming up, we will send out a news blast through that newsletter as well to let you know of upcoming events that you might be interested in. And this is just a survey link that we would like you to complete if you have a few minutes to let us know about how our webinar was today, as well as any upcoming webinar topics that you would like to see through the E-QIP team. So we encourage you to fill out that evaluation form to let us know of your experience with us today. So again, I wanted to just thank all of our panelists today for working with the E-QIP team to put on a webinar that has been really practical and hopefully useful. This topic has been of high demand from the sector as we're working with teams and agencies on quality improvement, so I'm sure it will be of value. Thank you all to the attendees for your patience on the technical difficulties today. I know it's not the easiest thing to stay focused, and we do thank you all for attending and sticking with us to the end of today. So I just ask that you all have a great afternoon, and just reach out if you need any support or have any questions from the team. Thanks again.
Thank you.
Thank you.
Thank you.